welcome everyone, and thank you so much for being here, and thank you for finding the room at UCLA. I want to thank UCLA. Let's give them a big hand for making this happen. It was so nice to have graduate students volunteering to help everyone find the room, and really wonderful food and drinks. And I'm glad everyone found the room. So thank you, and free parking too. I'm Giovanna Mbezi, and welcome to the LACNETS March meeting at UCLA. We have some amazing presentations today and some breaking news that you will be the first to hear in this room. Another good reason for coming live. I want to just make a couple of announcements. Our next meeting is going to be April 9th, which is a Saturday, and it will be at City of Hope. On your tables and being passed around are some flyers. City of Hope is doing a full-day conference that's actually for physicians. It's a continuing education credit. But they've invited LACNETS patients to come if they'd like, and there's a really impressive agenda for the day, which is also on your table. So you do need to register. They've opened it up to 75 patients or caregivers to come. So that should be a really wonderful day. And then looking ahead, we'll be back at Cedars in May, and June 25th is a date you want to put on your calendars. It's a Saturday. It'll be our annual conference at Cedars with lots of invited guests. I can't quite announce who they are yet, but you'll want to be there. And a representation from across the country and across the world. So that's going to be a very exciting day as well. So if there aren't any other announcements, just what we're going to do today is have the presentations, and then if you can save your personal questions for the round table for the second hour, the doctors have agreed to answer personal questions as well. So without further ado, I'd like to invite our first speaker to the podium. Please welcome Ken Herrmann. He is the director of Translational Imaging at the Ahmanson Institute Translational Imaging Division. That's a mouthful. And he has been working with UCLA and in Germany. He's been working with PRRT since 2004 and has some very exciting news for us, bringing PRRT to UCLA. So without further ado, please welcome Dr. Ken Herrmann.
Thank you very much. Yeah, first of all, welcome to UCLA. To my understanding, this is the first LACNETS meeting at UCLA. And you probably experienced, we're not very experienced yet at setting this up. It's our first meeting here. So it's a learning process. But I really hope that we welcome you back very soon again, and we will do better every time. Like Giovanna said, it's true that I have been in PRRT since 2004. And I can actually tell you exactly which date. It was August 16th. And the reason I know this, it was my first day of residency. And I came to the hospital, and I was immediately sent to the ward and was at least witnessing a patient undergoing PRRT. Some important disclosures, the financial ones and the important ones regarding to the neuroendocrine tumors are marked in red. I'm a member of the advisory board of Octopharm, unpaid, it's very important. And I have a couple of different scientific collaborations, and actually the two big players in the field of PRRT, and it's AAA, the Advanced Accelerator Applications, as well as Octopharm and Ipsen. And with both of them, we are trying to do research and to bring PRRT to the patients. And the most important, and probably the worst for you, is I'm German, so my thick accent is not going away, even after many years here in Los Angeles. As I'm not 100% sure that you will follow through my presentation to the end, I want to start with acknowledgements. These three people here are the people who made actually the first meeting, LACNET meeting at UCLA happen. Giovanna, you know very well Giovanna Mbezi, who was very helpful, very persistent, and also very supporting and very tolerating our baby steps in the beginning. Amber is the personal assistant of Johannes Czernin. She helped with everything, organized the parking and the food. And also very important, my boss and the chief of the Ahmanson division, Johannes Czernin, because he pays for everything. Now we come to the meat of my talk. So I kind of tried to selected different questions which I think could be of interest for you regarding PRRT. First, I want to discuss with you what is PRRT. And in the second part, I want to discuss with you the clinical evidence, some of the information you might have seen already, but I think redundancy always helps in this part. Then, of course, very important, how is PRRT administered? Very important, the fourth question, when will it be accessible? I also want to give you an outlook how PRRT is going to be potentially evolving in the future. And I, of course, want to introduce you to the UCLA NET team. When I explain PRRT to patients, and it's very complex, it's not as easy. And I always try to find examples. And one example is actually the Lego set. Most of you know from your kids or your grandchildren, is that you put certain things together. And what I mean in PRRT is actually that we have three different components. First of all, we need a target. So we need something which the tumor needs to express, so we can actually really have a ligand bind to it. The ligand is a substance which we inject, which really binds to the target, to the receptor, and it's like a key and a lock. Yeah? So the lock is actually the target, and the ligand is the key, and we need something which fits together very well. Now that we have something like that, we want also be sure that we get some therapeutic effect. And this is when the radionuclide comes in place, because the radionuclide actually is the one which really makes a treatment effect. And what does it mean in Lutathera or in dotatate in this case? Well, the somatostatin 2 receptor is a target. The ligand, and most of you have already heard about sandostatin or octreotide. This is actually the ligand. And the octreotide and other comparison is the key. The somatostatin 2 receptor is the lock. And then we combine it with a chelator to lutetium-177, which is a radioactive substance. And together, and this is for the future because I'm going to use very often the word of dotatate, it's actually the combination of the ligand and the chelator. And I have to announce that this is not my own slide. I actually stole this from one of my fellow postdocs. How does it work once it's injected into the body? The radioactive substance travels through your body and looks for the somatostatin receptor. And this is an example how the tumor cell, for example, looks like. The tumor cells express certain kind of receptors. And the nice thing about neuroendocrine tumors is that they express the somatostatin 2, 4, and 5 receptor. And this ligand binds to the receptor, then is taken up into the cell, and for the somatostatin agonist stays in the cells and the radioactivity decays there, making sure that the radioactivity, which is the treatment effect, is really delivered clearly to the tumor cell. As I showed you before, once we have the target and the ligand, we can connect this to any kind of different radioactive substance. And we can also do this to gallium-68. Gallium-68 is actually a PET isotope. It's not for treatment, it's for imaging, but it really helps us to provide very, very nice images. And this is just an example. Some of you already had scans. I know some of the patients here from scans at UCLA. Other ones maybe have it in the future. And just to explain to you is we have, of course, a very normal physiological distribution in the body. For example, this is a spleen, this is a kidney, this is a liver. You have physiological uptake. There's nothing we are concerned about. However, where you see the black arrows, you see that this is very focal uptake, which does not belong there. And if you look at the corresponding transaxial images here on the right side, again, where you can see the arrows, you can see these are very small lesions of metastasis. And even so, I appreciate very much the T information. Very often we have difficulties even knowing that there's a metastasis, finding it on the CT scan. So the combination of both really helps us to provide a very, very efficient diagnostic tool. And Giovanna previously said that we have a couple of exciting news. And one of the exciting news is that our IND, which has been granted for quite some time at UCLA and has always been limited to only one scan, is now open to 2 scans. So whoever already had a scan and still is in need of a scan, we can now finally provide this to you. If we combine this ligand, not with a PET isotope, but with a therapeutic isotope, the lutetium-177, we can treat patients. And I will go a little bit into detail afterwards, but the nice thing about the lutetium is it has a therapeutic component, but it also has an imaging component. And so we can, after the treatment, really make sure that the substance we injected really went to the tumor lesions. And this is an example of a patient, and you can see here, all these lesions here in the bones, for example, these are really tumor lesions where we made sure that the radioactive substance was delivered to the tumor is going to have an effect. And of course, we can also do this on a SPECT CT, and this makes the images, at least from the resolution, from the image quality, nicer. And here you can see that indeed the patient also got the radioactivity in the metastatic liver lesions. So now you say, okay, it's very nice, PRRT seems to work in some patients, but do you really have any kind of clinical evidence? And actually the first patient was treated 20 years ago in Switzerland, back then with yttrium-90, which is also one of the nuclides which is emitting the beta radiation, which has some therapeutic effect. And after the first components back there, a lot of patients were treated with either lutetium or yttrium, dotatate, and dotatoc. And this nowadays is standard of care in Europe. And we in nuclear medicine are very proud as this was finally accepted and also incorporated into the clinical guidelines of the European Society of Medical Oncology. However, and this was a very fair and very relevant question always asked by the oncologists is, do you have any randomized data? And I have to admit that until recently, there was a tremendous lack of randomized data. And this is where the NETA trial comes in place. And I know last time at CEDARS, Andrew Hendafer discussed with you extensively the NETA trial. I will reduce it to a few slides, but it's such an outstanding trial. It's such an important information that I think we cannot discuss it often enough. You all know that the patients had to have progression of the midgut tumor according to RECIST under the treatment of octreotide alone. And patients were then randomized into two groups. The one group of patients underwent 4 cycles of PRRT in addition to octreotide 30 milligrams. And the second group continued octreotide, but with a higher dose, with 60 milligrams. And this is now the real exciting slide, because now we look at the progression-free survival. And you have the green curve, which are the patients who underwent PRRT, compared to the curve of patients who underwent only octreotide. Now, it's always difficult to deal with this information, and how can we break down the information? And I think the most important part, and that's why I marked it actually on the left side in red, is the hazard ratio. And the hazard ratio tells me how likely is a patient undergoing progression compared in the arm with PRRT compared to the arm without PRRT. And the value of 0.21 means actually that patients who did not get PRRT had a 5-time higher likelihood of getting a progression than patients who underwent PRRT. So I'm a very skeptical person. So, you know, statistics always is nice to see a value, but I always want to see the confidence intervals. And I actually think the strength of this study is really the confidence intervals, because it tells me, in a negative perspective, how sure can I be that this PRRT is really improving the progression-free survival of patients? And this comes into place when you look at the 95% confidence intervals, and you can see here a value of 0.33, which means that even in the worst prognosis of or in the worst expectation from the data sample derived, the likelihood of undergoing progression if you do not get PRRT is 3 times higher than when you get PRRT. And this is really rock solid data. So this is really impressive, and that's why we cannot often enough discuss about that. A very important question in these patients, of course, is every therapy goes along with a certain kind of side effect. And I marked in yellow the things which I think are really relevant. First of all, serious adverse events. And if you compare the group of patients in the, who underwent PRRT, on the left side compared to the patients who did not undergo PRRT, you see the difference is not very significant. It's 26% compared to 24%. If you look at the percentage of patients who withdraw due to adverse events during the study, you see that the percentage is even a little bit higher for the patients who were randomized to the control arm compared to the patients who underwent PRRT. If you look in a little bit more detail, what are the side effects? And I really marked the ones which I think are important, where you see significant differences between the two groups, and especially regarding to grade 3 and 4. And I always try to explain grade 3 and 4 are side effects which patients usually also remember after half a year or a year after. So these are side effects which are quite significant, clinically manageable, but they are side effects which we should at least discuss about. And if you compare the two groups, you see the only few symptoms where patients really showed a significant higher percentage in the treatment arm compared to the control arm are the vomiting and the lymphopenia. The vomiting is most likely due to the amino acids. The therapy we apply, and most of you might have heard about it, has as a potential side effect nephrotoxicity. To protect the kidneys, we make sure that the patients undergo a certain infusion of amino acids before. Now, when the NETO trial was designed, people went to FDA and said, we would like to perform this trial, and we would like to do the kidney protection, which has been done in Europe for many, many years. And FDA said, no, we can't do that, because you have to use something which is FDA approved. And during the NETA trial, actually, patients underwent a combination of 24 different amino acids. And most likely, only 2 or 3 of them are really efficient. So a little bit unexpected, but this combination of more amino acids had as a very common side effect vomiting and also nausea. Something which is tolerable and also manageable with certain kind of medication, but something potentially which will go away once the new amino acid combinations, which we have been using in Europe for many, many years, is also accepted in the US. And I'm quite confident that this side effect is something which will be not seen anymore once that PRRT is FDA approved. The lymphopenia was a little bit surprising to me because I have not really noticed it during my clinical practice. However, this is nothing which was really coming to symptoms. This is a blood value. It's only temporary. And one of the potential explanations I was told is that potentially also lymphocytes express the somatostatin receptor. And as I told you before, the radioactive substance we inject looks for the key, looks for locks which suit. And if a lymphocyte has a corresponding lock, then it also binds there. Nevertheless, and I'm not going into details because of the limited time, but this was studied over time, and you could see that all the patients did very well after a few weeks, and the lymphocytes were normal again. The second page, nothing yellow means all the other symptoms were pretty much equally distributed between the treatment arm and the control arm. Now, kidney toxicity is a very important issue and something we really look at. And here in yellow again, the important information, there was no grade 3 or 4 kidney toxicity found in either of the 2 arms. A little bit more advanced is the lower part of the slide. It just shows you that the creatine value, which is a marker of the function of the kidney, has not really changed in any of the 2 arms if you look over time. And on a side note, to me, even a little bit surprisingly, it even increased in some of the patients, which of course is hard to believe. This is just a statistical fluctuation. So now the point, how do we really perform the administration of PRRT? Well, first of all, we have to prepare the patient. So it's very important to find out if the patient really expresses a somatostatin 2 receptor, because this is a target we really want to treat. And this can be done via the dotatate PET-CT scan. It's another example of a patient. Here you see again the physiological uptake. Where is it? In the spleen, you see the uptake in the kidneys, also in the adrenal glands, as well as in the hypothalamus. This is all very normal. But you also will now see that there are 2 dots which do not really belong there. And if you look in a little bit more detail, it's a patient with 2 liver metastases. But both lesions are highly somatostatin positive. This is a patient where we would say, yes, I'm very happy to offer you PRRT treatment. Once we have seen that the tumor expresses somatostatin 2 receptor, we perform blood tests, we do a test of the kidney function, and also we will consult the patient, explain the whole procedure to really make sure that he understands what's happening and also all the radiation things involved. Once this has been done, we schedule an appointment with the patient. In the future, this will be outpatient procedures. The length of the visit will be around 8 hours, more or less. The plan is to have the patient sit in one of these chairs, hopefully comfortable, because I'm very well aware that 8 hours is a very long time. What is happening with the patient with us? First of all, we are going to start the kidney protection. It's an amino acid infusion over 4 hours. And either in the middle of that or towards the end, we're going to perform the injection of the radionuclide. It's pretty much the same if we use dotatate, the Lutathera, or if we use the compound OPS-201 from the procedure is pretty much the same. And this will be infused over around 30 minutes. Then we wait another 4 hours after the end of the amino acid infusion because we want to perform blood tests. One of the side effects, not very common, not very often, but also something very easy to handle, is that the potassium goes up. So we will check the potassium after 4 hours after the end of the amino acid infusion, just to make sure that patients are fine. After this, patient can go home. And we will, of course, follow up the patient with repetitive blood tests and, of course, kidney function evaluations. And we will perform restaging. And this, again, is something we like to do with the gallium dilatate PET-CT scan. And you remember this patient example. This is really one of my patients. We performed the PET scan before the PRRT treatment. We re-performed the PET scan after 4 cycles of treatment, and you can see that the big lesion, the big liver lesion, got smaller, got a little bit necrotic. It's also less intense. And the second lesion is less intense, is still there. So this is a patient where we really feel happy if the kidney function is good to continue the treatment. We have patients, and I personally treated patients with up to 10 cycles. I know even people who treated patients up to 20 cycles, all depending on the kidney function. But I really want to show you that it's a treatment, if it works and the patient tolerates it well, it's something which you can do over and over and over again. And now, this is one of the very important questions. And this is something, actually, this slide I had to change from Sunday to Monday to this morning, because every 3 hours some new information came up. When will it be accessible? The short answer was the same all 3 days, very soon. The detailed answer is a little bit more complex, but I found out actually just yesterday that AAA was granted the expanded access IND. And early this morning at 3 o'clock, I also got a letter or an email that UCLA is welcome to submit all the paperwork that we will be enrolled as one of the trial sites. We hope to have the translation here at UCLA done within 6 to 8 weeks. I'm a person who likes very much sports. That's why I like the expression. I sent it around to my colleagues today. Now we are on the clock. So it's really, the ball is in our field. We have 6 to 8 weeks. Maybe it's 12 weeks. I really don't want to promise you, because UCLA is a big enterprise and things are always slow. But we really try hard, and we will put all our effort to get this trial started at UCLA. Very important question is also about the costs. The good information is that Lutathera, which is a big chunk of the costs, will be provided for free. We are currently working on a cost recovery mechanism for the other part, which means syringes, the time of the nurses, the time of the doctors. It's too early to tell you anything, but we are really trying hard to provide this to an acceptable and competitive price to you. And very important, and because this expanded access IND is good news, but of course cannot be the end of the journey. And the end of the journey must be the full FDA approval. And I heard from sources that they are optimistic that the full FDA approval for PRRT with Lutathera can be expected end of 2016, hopefully. And of course, reimbursement will then follow up a little bit later. Nevertheless, and I'm not allowed to make any advertisement, I was told, but I'm at least allowed to inform you that expanded access is really going to happen after months and months and almost years of saying we are going to open PRRT to patients. It's the first time, I just said it to Giovanna, it's the first time that I really believe that it will come along very soon. So I think it's always important also not to see what's already there, which has been in Europe for almost 20 years, but also important to see what's coming in the future. And as I showed you in my disclosure slide, we are trying to work with all the big players to really be able to offer cutting-edge healthcare here at UCLA. And one of the developments, and it's very early, but I still want to talk to you about it, is that in addition to the somatostatin agonists, there are also somatostatin antagonists available. The idea is that they have a better binding to the tumor, and this potentially means better images and also more radiation to the tumor. Now the big question is, how does it potentially work? I really have to tell you, no one knows. One of the ideas I show you here, one of the ideas is that the somatostatin agonist, the Lutathera here, binds only to the activated receptors. These are the ones in blue. Not all receptors on the cell are activated, and it is believed that the antagonist is a little bit less selective and therefore binds to all the receptors, the active and the inactive ones, hopefully getting more of these molecules to the tumor cell. Now, I personally haven't done any of these patients, so I show you data of good collaborators of mine. This is a group from Basel, and they performed PET scanning, just images with the same ligand, and here a total of 12 patients. And just to show you that there's really hope that potentially it might improve something, even though it's quite a few years along the way. You can see here it's again the liver, and you see 2, 3, maybe 4 lesions. if you look at the corresponding OPS202 scan, you can see here 1, 2, 3, 4, 5, 6, 7, 8 lesions. And this becomes a bit more obvious if you look at the corresponding maximum intensity projections. Again, this is one option to be better regarding the diagnosis, but it could also potentially be important to get higher doses to the tumor. And first patients have been treated. This was originally done in Freiburg, but the group moved now to Basel by Damian Wild. And this is an example of a patient who was treated with 2 cycles of this antagonist. And you can see here indeed that the lesions got smaller and some of them even vanished. Now, what is the current status? And I checked online, clinicaltrials.gov, and there is already a trial registered, but it's not yet recruiting. But I want to say that this is something, when patients undergo PRRT, and at a certain point maybe do not show response, there's still hope that potentially a new agent is coming along the way. And now I have the honor to introduce you to the UCLA NET team. It's something very exciting because Randy, who's going to talk after me, told me that this was in the plans for 10 to 15 years. And we just managed just recently to really set up an interdisciplinary team. And I'm very proud of it because it really involves all kinds of different professions. We have the GI endocrinology people, Tony Heaney and Joe Pesenia. Medical oncology is represented, and the people marked in red are actually here in the room by Randy, but also Zeph and John Glasby are doctors who really are committed to the UCLA NET program. We have the surgery division on board, Joe Heinz and Ronald Bosotil, both very famous pancreatic and liver surgeons. And of course, Tim Donohue, who's not only a friend of mine, but also one of the people who's really, really devoted to the UCLA NET team, and also the chief of pancreatic surgery at UCLA. And to the left, this is actually our group, the Ahmanson division, and consists of quite a few people, including people from the preclinical and also from the clinical side. And for example, Wolfgang is a nuclear medicine physician from Germany who has at least 6-7 years of experience in PRRT. Roger Slavik is a radiochemist who is the one who's really kind of doing the synthesis for us, and who's also working on new compounds. And Andreas Suparo is one of our biologists and chemists who's really helping us with the preclinical work. And of course, on the left side, and these 2 people are currently in the clinical, seeing patients, that's why they couldn't come, Martin Auerbach and Johannes Chernin, who really push together with me and hopefully bring PRRT very, very soon to UCLA. Now, how can you access the UCLA NET team? Well, there's a central phone number. I will leave the slide for a few seconds. And I'm also very happy to introduce you to Lauren and to Neisha. Please stand up quickly. They're here in the audience. And these are actually the persons, when you call the number, who's going to talk to you, who's going to help you, and to who you have to complain if one of us is not going to answer you. The future homepage is here. It's my task to build it. I need a few more weeks. But something which will, along the summer, will be available. And we have already founded a tumor board. And if patients want to access, have our opinion about certain things, this is really the phone number how you can access the UCLA NET team. Well, thank you very much. And I'm very happy to have you here. And talking about the Hershberg, this was our group participating in the Hershberger Run, supporting the research in pancreatic cancer.
Thank you. In the studies studying progression-free survival, what specific were events of what was considered progression?
This is actually RECIST criteria there. It's also like the inclusion criteria. That and RECIST criteria is actually a way of morphological imaging which includes CT and MRI. So they really looked at the scans and looked if the tumor got bigger, to simplify it.
Either bigger or more
on new lesions, yeah.
So that's a very standard that almost all cancers use. That you see RECIST, actually there's different RECIST 1.0, 1.1, old WHO. So what they did, which is really nice with these trials, is that they used a very standard way of looking at it rather than someone just looking at it, oh, it looks better or worse.
But it's exclusively based on tumor size and numbers, not on some blood work or
no.
lab.
Yeah.
Thank you.
And it's actually very consistent because the inclusion criteria was also based on RECIST. So it was really very stringent.
Oh, yeah. For the video.
Oh, I'm sorry. So the NETTER-1 trial was for grade 1 or all grades of tumors?
Low grade mid-gut tumors, Ki-67 less than 20%, if I remember correctly.
But it's indicated for foregut and...
Yeah.
Okay.
Right now, it's really only for midgut. Also, the expanded access IND is only open for midgut. But we have done in Europe peanuts, bronchial carcinoids, all kind of tumor. This is something where we really have to hopefully convince the FDA soon that we will be able to include these patients as well.
Hello. I noticed in your before-after pictures that one of the large tumors shrunk significantly, but there was a smaller one that didn't show much difference. I wonder if you could explain what's the difference between those lesions. Are some lesions not responsive to the treatment, or what?
There are many different ways actually possible. But actually in this patient, the most likely explanation is that you give a certain amount of radioactivity and the huge tumor gets a higher chunk of the radioactivity we inject and the small tumor only a little bit. The intensity even went down, but we saw a higher effect on the large tumor because there was just more mass and also consumed more of the radioactivity given. Nevertheless, it's possible that a tumor, or a patient who has many metastases, does potentially show a heterogeneous response. That's why we do not perform only the PET scan, we perform the CT scan also, just to be sure that the lesion does not only decrease in the uptake of the PET tracer, but also in size. And if this lesion gets bigger, then we get a little bit more concerned, and then we perform another scan to make sure that there's no differentiation. But in this example given, it was really the case that the big tumor consumed the majority of the radioactivity, and the patient benefited very much after cycle 5 and 6, because now the radioactivity was really taken up by the small tumor.
Dr. Herrmann, you showed one example, perhaps it was the same set of images that Dave was just referring to, where there was a couple of lesions in liver and the before and after PRRT. Yeah. I'm a little confused about what is the advantage or pros and cons of PRRT for that kind of a case with liver presence of tumors in contrast to chemo or radioembolization techniques. Why would one use PRRT versus the other techniques?
So first of all, it's, at least to my understanding, it's not so often that there's liver-only disease. So if you do a radioembolization or also like a selective radiotherapy with Y90, you can really only hit the liver. So if you have any kind of tumor in the lymph nodes, because I showed you there in this patient really only the liver. But usually patients have also a few lymph nodes or a bone lesion. So this is one of the advantages of PRRT, that we can hit everything. The second thing, and it's a very good question, and you can, of course, chemotherapy is also an option. This is beyond any question. And the advantage of the chemotherapy is similar to PRRT, that you would affect all tumor manifestations, not just in the liver. However, a patient who has only liver disease, maybe only also only in one lobe of the liver, it is always debatable to also perform a radioembolization. And what we actually do, we do in a combination. In patients who really have like 3 lesions and one is really huge, we sometimes even start with a selective radioembolization of the largest lesion, yeah, just to to decrease the tumor burden. And then we can make sure that the radioactivity we inject not only goes to the big tumor lesion, but also goes to the smaller tumor lesions. So it's not an exclusion. And I'm also not too competitive about it, because we really know that these patients who have neuroendocrine tumors luckily have a very long history. And I think there is a lot of place for every therapy at a different time point. And it's going to be our work in the future to figure out what is the right time point for which therapy, for which tumor entity. So, but that's why we are interdisciplinary, because we really try to find out together, involving medical oncology, gastroenterology, endocrinology, surgery, pathology, radiology, and us, to find out what is the best care for the patient.
This is actually a wonderful group. I'm Randy Hecht. I haven't been introduced yet, but I'm a medical oncologist. I guess visually introduce. You actually, this is a great group, and you asked a really important question. And the problem is that there is no right answer to that. And I think that's what Ken was trying to say. So, like one of my slides, you anticipated one of my slides, which the question is, how does PRRT really overlap? Because they're kind of like when you learned in grade school with Venn diagrams. There are patients who will benefit from liver-directed therapies. There are patients who have liver-only disease who will really probably benefit more from liver-directed therapies. There are people who have hormonal symptoms where liver-directed therapies may also help their hormonal symptoms if the other disease is not causing problems. And even though PRRT has been around for a long time, as Ken said, this is the first randomized trial. When you ask physicians, they really want randomized trials. The problem is in rare tumors that there are not a lot of randomized trials. And I think that a lot of it just really, you have to go, we have several multidisciplinary, we have the UCLA multidisciplinary board that we were just talking about, and also at UCLA, which I don't think I was going to talk about, is that we specialize in liver-directed therapies as well, and we have a separate hepatobiliary tumor board where we have the whole gamut ranging from surgery to radioembolization or SIR-spheres to bland embolization, which may also be reasonable, to even actually to transplant. This is the largest transplant program in the world historically. And so, but the question is that for any one patient, it's going to be an individualized answer for that.
Commenting on the fact that Randy hasn't been introduced, this is my job, and it's so many titles, that's why I have to read them. So he is Professor of Clinical Medicine. He is Director of the UCLA Oncology Program, GI Oncology Program. He's Director of Medical Oncology, and most important, he was one of the people from the beginning who really supported me in my efforts to bring PRRT to UCLA. And he's a very great collaborator, and I'm very happy to introduce Randy Hecht to you.
Can you all hear me okay? Okay. And so, but really that, you know, in some ways, I think many of my patients have come and they said, I've had to educate my physician before I was referred to a referral center. And so, so I'm actually, was thinking about what I would do to complement Ken. Ken is actually very humble. What you don't realize is that he really is on the cutting edge for not just PRRT, the treatment part, but for also the imaging. So many, if not most of you know that LACNETS is sort of the national organization. And at the last meeting, he is the person who actually gave the talk, the educational talk on the imaging. And the imaging and the treatment, as I think you saw, are really closely related. And so we're very, very excited. This has been a good week because we've been waiting. As I said, we've been waiting to put the program together for 15 years at least. We've been waiting though all the pieces have been here. We've waited really for a long time while we watched people. We've sent people to Europe. We've sent people, but as medical oncologists, we've been asking that question is please do a randomized trial. I know that you can do it, and does it help people? And over the last year, we found out the thing that we care about most, which is yes, it does help people. But so I was trying to think, and I looked back over some of the talks that have been given before. First of all, for those of you for the first time, this is actually not Cedars-Sinai, just so that you understand. This is actually Royce Hall. To be honest, I have never been in Royce Hall before, and so it's very nice. And I want to thank the NET team and Giovanna for setting this up. Just so that you also know that we don't see our patients here in Royce Hall. This would be a very large exam room. And actually most of our work is actually done, basically near where the hospital is and where Ken is, and also that many of us are also in Santa Monica as well. But I know this was, was hard for people to find perhaps, and I appreciate so many people coming up and hearing our talks. So I decided that I would actually try to follow up on at least some of the randomized trials. This has been, as I said, for the last, really up until a few years ago, there was a dearth of randomized trials because there were things that you could do, and we know that some people benefited, and the question was one better than the other? And I think the person who was just asked the last question is that we still don't have answers to a lot of those, and it's going to be hard to kind of parse those things out. Now, patients who are in the room know that there are really two things that cause problems for my patients, and I'm a medical oncologist. I also am lucky to work with Tony Heaney, who is an endocrinologist, and when people have more hormonal problems, he is really truly an expert as a card-carrying endocrinologist and as a card-carrying NET endocrinologist. What I generally work with are people who also are having hormonal problems, but the problems are on the scans, that the tumors are getting bigger or they're blocking something or they're causing problems. That being said, there's clearly an overlap. And while many patients have, particularly with pancreatic neuroendocrine tumors, have silent tumors, many of our patients have carcinoid syndrome. And really, for the thing that's helped our patients the most, of course, have been somatostatin analogs over the years. But the question has been, is there other things that we can do? Now, one of the things that we can do is actually reduce the amount of hormone-producing tissue. So if you treat the cancer and there are less hormones being produced, those patients do better. And that includes liver-directed therapy. That's actually one of the main reasons that we can do liver-directed therapy. Hope is something like PRRT would also help. But the other question, there's no pointer, right? And so, this is my long arm. And so, so at the NANETS meeting, there was the Telestar trial was presented. And this was one of the first randomized trials, really, this is the first randomized trial in many years with a new agent to help with people who have really intractable carcinoid syndrome. These are patients that you can't help by getting rid of the hormonal tissue, that you can't help by increasing their somatostatin analog. And I can't see it, but anyway. But if you go up to the upper, it'd be upper your right, is that kilotrostat is a drug that blocks the synthesis of serotonin. And it blocks basically by, it's a specific inhibitor of tryptophan hydroxylase. And that's the step that really is most important in regulating the synthesis of tryptophan. So therefore, the idea is that if you block up here, then what you can do is that then you don't have the symptoms downstream. So the problem historically, because this has been looked at over a number of years, is that there are reasons to have serotonin. And so you need serotonin for certain things, particularly from the neck up. And in fact, drugs that were originally designed to block serotonin had problems, and the one that was actually most important was depression. This drug, however, was designed not to cross what's called the blood-brain barrier. Now, our brains are protected from most poisons, okay, and that's called the blood-brain barrier. And it makes a lot of sense in order to do that. And so the problem is that our drugs block things, so you can think of them as poisons. And so therefore, most of our, that you want something that that doesn't go across the blood-brain barrier. So Matt Kulke, who many of you know, because he's run a number of the large trials, who's based in Boston, this was a randomized trial. And basically, these are patients who were on a somatostatin analog. It's a relatively small trial, but remember, this is a relatively rare tumor. So it was, there were only 35 patients for each of the three arms. And the three arms were either you continued just on the somatostatin analog with the placebo, you had a lower dose of the drug, or you had a higher dose of the drug. And what you can see is that, interestingly, and this happens, I'm originally a gastroenterologist before I became a medical oncologist, is that sometimes you can see changes with just a placebo alone. Because this was the number of bowel movements. That's why you need to have randomized trials, because there are differences that just happen when between when someone starts and then things change over time. But what you can see is either the 250 milligrams or the 500 milligrams, there was what's called a statistically significant reduction in the number of bowel movements each day. Now, we can have an ongoing discussion about how clinically significant this difference is, but I think for someone who is having severe diarrhea, this at least is an option. Now, the problem is that, the other way that they looked at it is how long did these last for, and there was an increase in the percentage of people who was considered a durable response. The problem is that it's really rare to to have a drug that has no side effects. And probably the closest you have is octreotide or lanreotide. But at least, and I just wanted to, because of the time, I only wanted to spend 20 minutes on all these together, is that particularly at the higher dose, they did seem to have some more other GI side effects. And the thing that I found a little bit most concerning, particularly at the higher dose, was there was a higher incidence of depression. As you can also see in the placebo arm, there was also patients who ended up having depression. So that's why another reason you have to have placebo-controlled trials. So I think it may be useful in patients who have refractory, luckily that's not the majority of our patients. As I mentioned, there's some additional toxicity. And the question is whether we should do this first or whether we should be looking at other ways basically to try to shrink the tumor at the same time and reduce the amount of hormone-producing cancer. So the other large trial that was presented at the NANETS meeting, and at least partially presented again, it was called the GI ASCO or GI Cancer Symposium meeting, was the RADIANT trial. Now, how many people, because some of my patients, a number of my patients, most of these are most of you are Cedars people. We had some problems with finding out how to send my patients over here. But some of you may actually have taken part in the Radiant trials. Did anyone here taken part of the various Radiant trials? Okay. But because we took part in them, so a reasonable number of our patients did. So everolimus, or Afinitor, the original name for that was RAD001, and that was rapamycin analog. And it's harder, but basically, this is a derivative, called, everolimus is a derivative of actually a natural compound called rapamycin that blocks a signaling pathway called the mTOR pathway. And interestingly, there's some cancers that seem to be very sensitive to this. Breast cancer actually is one. It's been looked at a lot of other cancers, and the other one that seems to be important is neuroendocrine tumors. So Novartis that makes this drug looked at it in a couple different, they made some earlier trials, they were all called, because it was RAD001, they were all called Radiant trials. The one that got the drug approved in this was the Radiant-3 trial. These are patients with pancreatic neuroendocrine tumors, and this is actually what the label is. This was a large randomized trial. Everolimus, or Afinitor, is the name of the drug, versus BSC as best supportive care. So it was with a placebo. It was a placebo-controlled trial. Presented a number of years ago. And what you can see is progression-free survival. As Dr. Herrmann mentioned, progression-free survival is a very reasonable endpoint. And what that means is just how long did it take for the tumor to get worse on scans, not by labs. We don't use that generally for our trials. But how long did it take for the patient to get worse by scans, where these very specific criteria. And what you can see is that the patients who are on everolimus, this is what's called a Kaplan-Meier curve. And what a Kaplan-Meier curve is that everyone starts on study at 100% of the patients are on there. And with time, which is going this way, people fall off, either because they have side effects, either because they decide they don't want to be on it anymore, or because the tumor gets worse. And what you can see is that more people stayed on longer on the everolimus arm than they did on placebo alone. Okay, and the hazard ratio, which Dr. Herrmann mentioned, was about 0.35, which means that at any point over time, there was about 65% improvement on whether being on placebo versus everolimus or Afinitor. This got the drug approved a couple years ago. At the same time, there was another trial which we also took part in, which was called Radiant-2. And this is basically identical design, though larger, because carcinoid is more common, for patients with carcinoid as opposed to pancreatic neuroendocrine tumor. And this trial, even though there was a reduction, so you can see the blue line is on top, did not hit the statistical endpoint. And I think Dr. Herrmann mentioned is that the problem is that whenever I do trials for a living, there's always a chance that one arm may do better than the other just by random chance. So what you do is you'll see what's called a p-value up there, and also the hazard ratio. Boy, I can look that way. But the hazard ratio is not as good. And what it meant was that, this is really getting to the statistical weeds, but it did not hit its pre-specified endpoint. And so the FDA said, you might have some activity here, but we're not going to prove it. So Novartis went back. In fact, I know the person who ran these trials from Novartis, David Lebwohl, and decided to actually spend the money and run it again. And James Yao presented this. It's been presented at least twice. This was Radiant-4. This was either lung or GI neuroendocrine tumors, so not pancreatic neuroendocrine tumors. Trial design looks very similar, though there was what's called a 2-to-1 randomization, which means that rather than flipping a coin, 2 out of every 3 patients ended up getting on the everolimus. The thing I will have to say is that we have been able to get everolimus for our patients with carcinoid by hook or by crook. And interestingly, running the trial again, actually the patients did better. This is why you have to show statistical significance. They didn't really change things that much, but basically patients were about half as likely to progress, in other words, to come off the study at any one point, because the hazard ratio is 0.48. So patients did better on the everolimus rather than placebo. And so this is now, I think within the last week or two, now has FDA approval for this. Though, as I said, we were able to get this. Survival was actually pretty similar. though you could see there was something favoring, there was a little bit favoring everolimus. The other thing is there was a lot of what's called crossover, so people who are on the placebo arm often managed to get everolimus. And so that's one reason why for our trials we actually look at progression-free survival, but patients don't care about progression-free survival, they care more about overall survival. But from a study standpoint, the problem is that you can't really tell people what to do after they come off your trial. So, but at least it was still heading in the right direction, and I think this is a good thing. And this is a reasonable option for our, for our patients. So patients did well. The other problem is that we actually have the luxury that we have many different treatments now for our neuroendocrine tumor patients, ranging from drugs, ranging from cytoreductive or basically destructive things, particularly in the liver, ranging to somatostatin analogs, and now with PRRT. So this is actually part of what we do, is trying to fit it all in together. NETTER1, I don't think I'm going to talk about, because that was the other, of course, major one that was talked about. The only other thing that I'm going to talk about, we had a discussion last night, Ken and I, and so this is probably the most important thing, the progression-free survival. But as an oncologist, there are two other things that I like to look at. One is that some of my patients, not most of them, but some of my patients have so much tumor that it's actually causing problems, where they're uncomfortable, particularly tumor in the liver. And so we use what's called response rate. Now, response rate also is not what you would think. Okay, so our specific definition, I would think, and until I became an oncologist, even as a gastroenterologist, I thought that response meant the patient did better, right? They responded. And so, but actually there are these very specific criteria, what Ken was talking about, the RECIST criteria. So basically when we say response, we mean it shrank a lot. And so that's a major response. So what you can see is that people at PRRT were a lot more likely to have this major response by the way that it's measured. Actually, tumor volume may even be better than that, because I think actually the scan that you showed was perfect. Because what you saw was a big tumor, and what it did is, Ken used the medical word, which is necrotic. Now, necrotic means it died inside. So even if the radiologist measures it the same way, in other words, you look at the scan, they put a little caliper on it and all that, that tumor is significantly smaller. And that may or may not be picked up by the ways that we do this. So if I have a patient who actually needs a response and the tumors need to shrink, and most of the other drugs that we use, the response rate, major response rate is not that low, I think this is actually something that's interesting. The other thing is that we had a discussion about this last night as well. He decided not to put this in, but I decided to leave this in. For my patients, and as an oncologist, I take care of the patient from the time they walk into the door as long as they want me to take care of them. So one of the things I care about is not just progression-free survival, but overall survival. That's what the oncologists talk about. And that's what the patients often want to talk about. I think all the caveats that he brought up were exactly right, especially people with neuroendocrine tumors, because they tend to do well, which is a good thing. But you don't have any control over what happens after the PRRT. And these numbers are small. But basically, not only did people's tumors not grow, but they were less likely to die. And this p-value is showing that it's probably not due to chance alone. So not only is it not keeping the tumors from growing, the progression-free survival, but it seems to be improving even though this was not what's called the primary endpoint. What I'm really interested in as well is the overall survival, and it will take a long time for us to get more data from this. And then you already talked about this. So as a medical oncologist, we've been dealing with PRRT and our patients going to various places for a long time. And we keep saying, please do a randomized trial. And one of the problems is that this is not a drug. As medical oncologists, for our drugs really to be prescribed, you have to do randomized trials. But this was a way to give radiation, and it was just been hard to try to figure out how to do it. So I really have to give the NETTER1 group and the nuclear medicine, and the molecular imaging community a lot of credit for finally doing the randomized trial. And to be honest, I have to say the data was better than I thought it was going to be, looking at the earlier studies. And maybe that's because people like Ken have been doing this for so long that we know how to, that it's been optimized over the years, mostly in Europe. I think someone also brought up the question, I think Ken also brought up, how long can you repeat? I think the trial only allowed 4 sessions. And so it'll be interesting to see what happens after FDA approval. We're sort of stuck with the way that the protocol, the original trial was done in the expansion cohort. Later on, you theoretically could do it as much, your physician, you can order it, Ken can order it, you can do it as much as you want. What I don't know, of course, is what's going to be paid for also by insurance, which I think will be something that will be worked out. Also overlapping with other therapies, for example, liver-directed therapies, not just locally destructive therapies like embolization, but also when you're giving more radiation to liver with Y90. My discussions with my nuclear medicine colleagues has been that it seems to be okay that even people who've had Y90, but that's a concern because many of our patients have, you're giving additional radiation, particularly if you have liver lesions. But one of the wonderful things about the liver is that it grows back. Unlike almost any other organ, you can get rid of 2/3 of someone's liver and it will grow back. And that's why we cut out neuroendocrine tumors. He mentioned the amino acid mixture. I think neuroimaging is actually really critical. And so I think he glossed over this a little bit, and this is something that Ken has really been working on, is that my hope is that the octreotide scan no one will talk about that except from a historical standpoint. And I think the gallium dotatate scan will be what we expect, and that will be the standard of care and really what we expect for our patients. And I think it's really important because if they have more disease than we thought, it's important for us to know that. And particularly in the setting of doing large surgeries or even transplant, you want to know that ahead of time. And I think he also mentions there are also next generation agents as well down the pike. So this has been an exciting year, not just because we finally put our program together, so that's exciting for us. And we've been seeing for years, it's not that we just suddenly started seeing neuroendocrine tumors, we just haven't been necessarily always doing it together. But there have been several advances, particularly I would say in carcinoid with Radiant-4. What we really need to learn to do, and a lot of this is just from seeing lots and lots of patients, is how do we sequence those patients? And every patient is different. The patient who has a large volume of disease and has a lot of hormonal symptoms is different than the patient who has an incidentally found carcinoid and is completely asymptomatic. There are differences still between carcinoids of the midgut or GI carcinoids and carcinoids outside the GI tract, which we really won't talk about today. And I think there's still, even though patients are doing better, we're still not curing patients with PRRT. We're not curing patients with everolimus. And I think there's clearly a need for trials and something that we're really interested in and a need for new agents. And I think that's it. And that's, I think, Royce Hall. Thank you.
Dr. Hecht, I have a question. You mentioned Dr. Heaney and Dr. Herrmann's here. Can you talk a little bit about the team at UCLA and the NET team?
So, I guess I have to use this. One of the really interesting things, so you have to love what you do, but one of the really interesting things about neuroendocrine tumors, and you have to love to take care of patients, is because so many different doctors are involved. And so what we do is that one of the nice things about being at a place like UCLA is that not all patients need any one doctor. Now, I think most patients end up eventually needing a medical oncologist, but not all patients at any one time need a doctor, need a specific doctor. So, for example, Tony Heaney does research in neuroendocrine tumors. He works in not just the type of neuroendocrine tumors we're generally talking about. He also works in other rare neuroendocrine tumors as well. And as an endocrinologist, he works a lot, and I consult with him, particularly when I'm concerned about patients with refractory carcinoid syndrome or symptoms, or people who are undergoing procedures where I'm worried about carcinoid crisis. And he's at UCLA and actually also was one of the people speaking at NANETS at our national or international meeting. Actually, Tony was speaking specifically from an endocrinology viewpoint of NETs, giving one of the lectures. The other people that we work with, for example, not every person is going to need liver-directed therapies, but we have a wonderful group, and not every person is going to need a transplant or is eligible for a transplant, and we work with them as well. But I think the core people for much of what we do are going to be the medical oncologists, because we're the people who take care of the patients long term, and the great news is that for most people it is long term, and also the nuclear medicine people, because imaging is such an important part of what we do. I don't know if that's a long answer to a short question.
Great answer. Does anyone have any general questions before we break to the more personalized ones?
Yes, ma'am.
Called ACOR. Oh, sorry, I just read on the ACOR website last night that they have just undergone or commenced a new trial on the oncolytic virus treatment. It's being done, I believe, in Sweden. Are you familiar with it or with this?
I think I can hear you quite. I don't think that's
Oh.
that microphone is on, but about
Oh.
oncolytic viruses.
Yeah.
I think that there are
so. Just started. They just started. It's not
Yeah,
treatment,
so,
but
I mean, I'm very
trial.
familiar with
Sorry.
oncolytic viruses, and so I've actually been a virus hand since the 1990s. I've run virus trials, and in fact, I'm actually running an international oncolytic virus trial, though not in, unfortunately, in neuroendocrine tumors, but I'm running a trial in colon cancer and a number of other tumors as well with an oncolytic virus. It's called TVEC, which is actually FDA approved in melanoma. And so for people who don't know what oncolytic virus is, and so there's been a lot recently, particularly in sort of, I think it was Vice, if I remember correctly, but in brain tumors. And so people have been really puttering around with viruses since the 1990s. And the idea is that viruses are designed to get into cells, and often they kill cells. So those are two really good things. So from a cancer treatment standpoint. So one is that you want to make certain that if you're trying to get something into a cancer cell, that's a way to get it in, just like with somatostatin analogs and somatostatin receptors. The other thing is that they kill cells, and that's the lytic part. So oncolytic means kills cancer. That's basically a fancy way of saying that. And the other thing that it can carry in, and this overlaps in two things. For a long time we were thinking about it from a gene therapy standpoint, where you could bring genes in and maybe cause the cancer cells to be more susceptible to whatever it is you're giving them. And then the other is, and more recently, and this, for example, my trials, and this was not what we were thinking about when we were first doing virus trials back in the late 1990s and early 2000s, is that our bodies are actually very designed to fight off viruses. So a large part of our immune system is actually designed to kill cells that are infected with viruses. T cells, for example. That's really, from an evolutionary standpoint, what they're supposed to do. Now, those infected cells, which have turned into virus factories, are somewhat different. And that's what we're supposed to recognize as things that are different. That's what the immune system is supposed to recognize, things that are different, and to kill them. Well, it happens that our immune system is not really as well designed to pick up cancer cells, but it picks up things that are, cancer cells are different. So the idea, I'm trying to make this sort of in a lay term, is that what you would like to do is an oncolytic virus, what we were originally trying to do is hoping it would infect all the cancer cells and then it would wipe things out. That didn't work so well. Okay. There are some, like for example, in brain tumors where you can inject the virus directly into the brain tumor. There have been a number of trials with that. But I think most of us who are doing oncolytic viruses, viral therapies, and really are looking at it as a way to kind of drum up an immune response. Because people always say, well, I want to boost my immune system. I don't know what that means. That's a way for people to say, I don't know what that means. But we want a specific immune response against people's cancer cells. And the idea is if we infect the cancers with viruses, then suddenly the immune system will wake up and say, hey, this is something that's not supposed to be there, and attack it, rather than the virus itself necessarily causing most of the benefit. I think it's interesting, but we have had lots and lots of trials. Please show me the data. There are a number of other immune therapy trials that people are looking at. We're actually discussing this last night. There are all sorts of, immunotherapy is now kind of the great revolution in cancer care. But I think it's interesting, so I always encourage people to go on trials, but I'm not aware of any data for that. But I just wanted to explain, because people often ask me what are oncolytic viruses and how does this fit in. Oh, you're welcome.
Thank you, Dr. Hecht and Dr. Herrmann. I'd like to invite you back up, and we can take additional questions. Thank you very much for all being here, and maybe if you would like to take a seat at the table, and we're going to stop filming now, and so feel free to add all your personal information in. Thanks.